morning and welcome to our Women's Health webinar series. Today we will be talking about COVID-19 and pregnancy studies. What have we learned so far? How do we sift through all the data? And what research do we have in the pipeline? My name is Dr. Nazanin Homofar and I'm an obstetrician gynecologist at UCSF. I've continued to see prenatal patients in clinic and on our labor and delivery unit through shelter in place. And I have to say, it's been a struggle to keep up with the influx of data regarding COVID-19 and pregnancy. There was a New York Times study published on July 10th titled, "Why We Still Don't Know Enough About COVID-19 and Pregnancy," that highlighted some of the challenges we faced. The studies that make headlines can sound terrifying, and in speaking to patients and friends who are currently pregnant, I've sensed frustration, anxiety, and confusion. Why don't we know more? Why can't we get data more quickly? I hope this webinar will serve as a launching point to answer some of those questions. While we prepare to introduce our speakers, please help us get a sense of who is tuning in today by filling out this poll. I'm going to close my door in the meantime. And Matthew, if you can launch both of the questions at once, if possible. While we give you a chance to respond, I'd like to introduce our wonderful panelists and give you insight as to how we will use this hour. I'm very happy to have with us Dr. Stephanie Gaw, who's an MD, PhD, and assistant professor of maternal fetal medicine. She's the co-principal investigator of the Priority Study and co-investigator of the Aspire study. We have Dr. Karen A. Scott, who has an MD, MPH, and is board certified OBGYN. She is an associate professor of OBGYN, principal investigator of the Sacred Birth Study, and the founding and co-investigator for the HOPE study. We also have Dr. Eleni Greenwood-Jaswa, who is an MD, also has a master's in science. She's assistant professor of reproductive endocrinology and infertility at UCSF and co-principal investigator of the Aspire study. Let's see if we got any poll results. I'm not sure if we got the poll to launch. Oh, perfect. Okay, so of the 57 of you, we have 35%. So a third of you are in your basically second to third trimester. A quarter of you are in that third trimester. Some of you are thinking about getting pregnant, and one of you is postpartum. And to whoever is joining postpartum, congrats. That's a huge feat to be able to do in the midst of everything that is going on. I'd love to share the next poll question as I continue talking, just to get a sense of where you're getting your information. Many of you have sent great questions ahead of the webinar, and we intend to answer as many of them as possible. The ones that we are going to choose to answer, though, are really centered around the webinar topic of research studies and what do we know. Many of you have great questions about our UCSF specific policies. You would like some more guidance as to how we should think about travel or working, and we're hoping that some of the studies we share with you will touch upon that, but I will be holding another webinar in the future to go over some of those specific guidelines. We really would like to use these 45 minutes to discuss what we know about COVID-19 so far, and we'll be publishing either FAQs or our PowerPoints specific to the UCSF policies in the future. Matthew, do we have a vote on resources people have used? This was one that I was very interested in knowing. Great, I'm happy that 38% of you have been able to get information from your healthcare provider and practice. 25% of you have relied on traditional media as well, so newspapers, TV news. 35% of you, wow, this is impressive, have gone to the professional organizations to look up what they've said. So the CDC, the American College of Obstetrics and Gynecology, and the WHO. I think I'm happy to see only 2% of you have primarily relied on social media, and no one is relying on friends and family. Great. I think this is going to be hopefully a very fruitful conversation for everyone. Without further ado, I'd love to get started, and I'd like to start with Dr. Stephanie Gaw, and then we'll move to Dr. Karen A. Scott, and then Dr. Jaswa. Dr. Gaw, we're going to speak to you for the majority of the talk to really get a sense of what we know, how we get to a place where we are getting the data and the practice guidelines from professional organizations. As of July 21st, the CDC published 12,969 cases of COVID-19 in pregnant patients and 35 deaths in the United States. Dr. Gaw, we have about 30 minutes to hear your expertise, and I really want to center our conversation on 3 aspects. And I'd love to have Matthew share your slides. I would like us to focus on how do our professional organizations weigh in during pandemics? And then how do we sift through the early data, and what can we say with some level of certainty about COVID-19 and its effects on the pregnant woman, the fetus, and the newborn? So Dr. Gott, let's start with that first question. How do professional organizations weigh in during pandemics?
Thank you so much for the invitation to speak today. These are all really important concepts to understand, and a lot of what everybody's going through, pregnant women, their families, and providers, as we figure out what is the best thing to do during the pandemic. And we are clearly still trying to figure it out. And I hope that that's kind of the bottom line message from our conversation today. I hope that by the end it can give you a summary of what we do know at this point, and with the understanding that things are changing very quickly, and it's really hard for even the scientists, doctors, and researchers to sift through the data and understand it. And so we know that it can be very overwhelming for non-scientific or medical professionals to understand. Next slide. So as far as the professional organizations, so these are the main professional organizations that have been issuing guidelines, committee statements, opinion statements on how to care for people that are affected with COVID during pregnancy, in the labor and delivery process, and also for the babies after birth and beyond. So the main ones are the American College of Obstetricians and Gynecologists, which is a governing professional organization for OBGYNs in the United States. The Society of Maternal Fetal Medicine is a subspecialty organization of maternal fetal medicine specialists. So we are specialists in high-risk pregnancies. And so there's a little bit more information for practitioners that are involved with high-risk pregnancies, for example, if you are diagnosed with COVID. The American Academy of Pediatrics guides from the moment the baby's born and afterwards, and guides the management of the babies after they're delivered. And the Centers for Disease Control, the CDC, obviously has national data for national guidelines for how to manage COVID-19 in the general population, and sometimes they have some guidance for pregnancy as well, which they do for COVID. Next slide. And so
sorry, if I can interrupt Dr. Gott while we transition to that next slide. Like, I see all these organizations, and one of the frustrations I had is that I wasn't seeing statements come out from our professional organizations what I thought was fast enough. even though we didn't know much about what we should be doing, and at least what precautions should we be taking with pregnant patients. Can you tell me a little bit more about that? And maybe it'll be answered in this slide.
Yeah, I think that with the COVID-19 pandemic, everybody has been starving for information even before there was any available. And so, I think there was, actually, honestly, it's hard for me to remember back from the very beginning because it seems so long ago, but I do think that, ACOG came out with an early statement. SMFM came out with an early statement, I think probably in March. But the problem was at that point, there was so little information that there wasn't very much that they could say with confidence to guide practice and to guide patients. So when these professional organizations are coming up with their statements, they have to take in certain considerations. And for one, I am not on any of these, committees where they come up with the statements myself, but knowing other people that are on them and understanding what the process, each of the organizations comes up, basically formed a kind of an expert consensus panel very quickly with key experts in that field from across the country. And so most of the statements come from their consensus. And the primary thing they have to consider is what is the evidence that, what can they say that is true, right? And so what does the medical literature say so far? We don't want guesses. We don't want, if we can, we don't want people to make conjectures. And so they really, had the very challenging task of trying to compile the little literature at the beginning to poor quality literature to constantly changing information as things came out so quickly. And then the next thing they have to think about when they come up with their statement is what is the potential impact of the statement? For one, on the individual person reading it, like the pregnant patient and their families, and also at a national level. What do their statements mean? If they come up with if they, for example, came out and said with very little data that, pregnancy is probably very high risk, does that mean that all of a sudden all pregnant women are going to lock themselves up and not see anybody? And could that possibly cause more harm, anxiety than good? So they are very limited by what is established published data and, balancing the repercussions of their message overall, and that their clear recommendation should be safe and practical for everybody involved. When you look at the different organizations, again, they all have different target audiences, right? So some of them overlap, the majority do. But again, like a WHO guideline is for the whole world, and then depending on where you live, their recommendations may be very different from a CDC guideline, which is targeted towards the United States. And then again, a recommendation from an OBGYN may be different than a recommendation for a pediatrician, right?
That makes sense. I know, I think I was hoping, as I think many of the people I talked to, is there anything we can extrapolate from other viral illnesses that we know that we have some more better information on, like SARS, like influenza. And I think you'll get to that in your next few slides, but what was it, could we have made any other conclusions, even though we didn't have the certainty of the data, to at least give people a little bit more guidance?
Yeah, I think, I think the initial ACOG statement, some of us were a little bit frustrated by, because I think again, this is where language is very important. I think they said something like, to date, there's no evidence to suggest that pregnant women are at higher risk, which basically meant there was no evidence at all at that point. But it's not that we knew that they weren't at higher risk, it's just there wasn't, yeah, exactly. And sorting through all that has been very challenging. But I do think we've come a long way in the past 6 months with a lot more data. And now it's trying to understand what data is relevant and meaningful to, each individual patient and to guide policies, both at the hospital level and nationally.
Can we talk about that? Because every day, Matthew, you can go to the next slide. Every day there's a new headline, and I find it to be, as a physician who knows how to look at studies or who can read some medical literature, even I'm confused. I'm like, oh, I thought I just saw the headline that said first evidence of baby contracting COVID-19, discovered. And share some of these headlines with us. Tell us, like, how do we sift through the data and the headlines? How do we know how to weigh all the different studies that are coming out?
Yeah, I think this is something that all of us struggle with. So this is just a sampling of recent headlines from the New York Times alone, not even looking kind of outside at other news media agencies, where you can see there's a variety of headlines. There is, to focus on this one, study raises concern for pregnant women with the coronavirus. Pregnant women who are infected wind up in hospitals and ICUs at higher rates, a federal analysis suggests, but the data is far from conclusive. So this is referring to the CDC paper that was published recently, describing nationally reported data on COVID-19 and pregnancy. But there are a lot of caveats with understanding what that data meant. For example, just this part, pregnant women who are infected wind up in hospitals at higher rates. The CDC data was unable to distinguish why women were hospitalized. And as we know, the majority of pregnant women in the United States are hospitalized for labor and delivery. And it didn't distinguish that. So it doesn't necessarily mean that women are hospitalized because of COVID.
Okay. I wanted to clarify that, because you're saying a lot of good things, and I think it's really important to highlight. So when we see a headline that says pregnant women who are infected wind up in hospitals and ICUs at higher rates, much of that data is conflated by the fact that many of these admissions could have been for pregnancy-related symptoms or causes that are totally unrelated to COVID.
Exactly. And they, the CDC paper in the details, if you read the paper, they do address that. But again, it doesn't make the headlines because it's too confusing or not as exciting. And so that's where it becomes very challenging to read these and understand what's going on. I think, to talk about that CDC paper kind of specifically, I think there are many limitations. It's the best data we have on a national level at this point, but the major limitation is that it's really just hospitals voluntarily reporting on pregnant women that are COVID positive with very little data. They just check a box if they're pregnant and if they're hospitalized, but they don't say why they're hospitalized. The majority of pregnant women are in the hospital because they have a baby, and some of them are in the ICU because of a pregnancy-related complication, not necessarily COVID. So we don't understand exactly what's happening, but more data is to come, hopefully.
I know you're not the head of the CDC, but why isn't it easier to just ask hospitals to report this data?
I
think
that, talking to people that have worked at the CDC and also currently work at the CDC, they are a government agency with very limited resources. And I will say pregnancy is is also kind of a subset of the larger population, which is very complicated, and the systems that were not in place in time. We were not, as an agency, in order to be able to collect that data accurately from the very beginning. I think, even their first case report form didn't include pregnancy, and then they came up later with a separate pregnancy report form. And again, there's no way to really enforce reporting, and that's another problem, right? So for example, if you are in a very highly impacted area and you are just dealing with very sick patients, reporting kind of falls down and maybe delayed even from the time that you're actually seeing the patient. So, I think eventually there will be a good enough database from this where they can try to sort through some of it, but there's always limitations with these national cohorts.
And I want to make a point to our listeners too, that we have difficulty collecting even the most basic data about pregnancy and hospital admissions for patients as is. So many states will have agencies that will collect quality improvement data on the number of hemorrhages or cases where people are bleeding much more than we would expect, or the number of maternal unfortunate deaths or people who have high blood pressure disorders. We are struggling even in the state of California to make sure that all hospitals report data to an organization that can look at this data and compare what the outcomes are in the hospital. So I think it's important to understand that it's unfortunate and it's something that we have to work on and be better at, but we don't even have a way of enforcing that hospitals report their data consistently to an agency now, so that when we are hit with a pandemic, it's an even bigger issue to then try and create a funnel of information that's consistently going to one place. So I think that was something that I was thinking of too when trying to explain to people, why is this so hard? So it looks like, Dr. Goss, since February 2020.
Yeah, so this is basically, so the CDC and Johns Hopkins have a kind of they have a listserv they basically actively compile these pregnancies. So every week they send out a list of curated papers that have been published. And on the area of maternal child health, there have been over 1,400 papers published since February. I get weekly updates, and every week there are 100 to 200 papers added every week. So it is an almost impossible task to actively keep up with all of them. There's varying degrees of quality of the papers, and a lot of them, and I think trying to understand how to manage all that data, put it in context with what we know and how it affects, how it should affect our practice here in the United States, and then two here in San Francisco in our hospital system is another level that can be very overwhelming, honestly. I think for going to for the goal of this seminar, I think I'd like to provide some sort of a framework for, as studies come out, like it's impossible to go through every study in detail. No one person can say predict which one will be good studies, which ones won't, but some things to keep in mind as these reports come out and as you're reading the literature, as a framework for trying to understand where to put that information in your head.
That would be great.
Next slide. So when you're looking at medical literature, scientific evidence, there are many different types of studies, and some are much better than other studies to answer specific questions, right? So this kind of is a very general grouping, but to give you an idea of what carries more weight in the evaluation of a study, and which ones to take more seriously, I guess. So at the top of the level are systematic reviews and meta-analysis. And I kind of, this with a little bit of a asterisk, because you can also have bad meta-analyses in which but systematic reviews and meta-analyses are where they try to look at all the studies that have been published trying to answer one specific question. For example, in COVID, is there transplacental transmission? Is it possible for the virus to cross the placenta from the mom to the baby? So they will go through and pull all those studies that are available at that time. They'll rank them by how good they are and whether or not they're able to answer the question. And they'll try to summarize everything all together to make that study a bigger study. Some of them are very good. Some of them are, the lower quality ones will be the ones where I think, especially for COVID, I'll say that people came out with meta-analyses 1 month in, so there were only 3 studies included in the meta-analysis. So just because it says meta-analysis in the title, it doesn't necessarily mean it's a very good study. You have to look at how many studies are looked at it over what time period, right? Randomized controlled trials are when it's like a true human experiment, right? We'll take patients and this is classically for treatments, right? There are 100 patients with COVID and we take 50, give them this treatment, and 50 don't get treatment. And you see which one, and that's really the only way to tell whether or not the treatment works, right? Because it's not biased by the provider wanting to treat someone or the patient wanting a treatment or refusing a treatment. They are randomly assigned to treatment or no treatment. There have been very few randomized controlled trials in COVID so far, and none that include pregnant women. The majority of COVID studies are going to be observational, or the last one, expert opinions or anecdotes. So observational research is cohort studies where we identify a group of interest, such as pregnant people with COVID, and then we follow them to see what happens. We can also look at kind of a little bit backwards. They're called case control studies, where we have an outcome. Let's look at pregnant women that were admitted to the ICU because of COVID and compare those with, pregnant women with COVID that were not admitted to ICU, and try to figure out if there's any risk factors that made ICU admission more likely, or any clinical signs or lab values. And then case series are collections of patient cases with a similar either diagnosis or similar outcome. And those are mostly descriptive to say, out of 100 patients we had with COVID, this is what happened with them. This is where the bulk of COVID research is at this point. And again, there's kind of varying levels of quote unquote quality in the amount of data and the quality of data collected and reported, and also the number of patients. You can imagine a cohort study with 2,000 patients with documented COVID infection is going to be much more informative than a cohort study of only 15 patients, right? Because it's hard to distinguish what happened because of COVID truly or by chance. Animal and sorry, go ahead.
Sorry, I was going to say, I'd love to, we have about 10 minutes left, and I'd love to see, so what can we take with certainty from the studies? Because we've seen the headlines. They can be alarming. How much weight should we put on them?
I would say the larger kind of national databases, more weight than the case reports. For example, that one headline about the case in France where it looked like the virus was transmitted from the mom to the baby. Overall, the more patients, the better, and then the better followed as well.
Okay, so let's move on then to what we know with some certainty, if we can go to the next slide, about COVID-19, or sorry, tell us about the priority study first, Dr. Gomez, and then we'll go into it.
I'm one of the co-principal investigators of the priority study, which was launched out of UCSF here in collaboration with my colleagues at UCLA. And this is a national registry. It's a cohort of women that are women or people that are pregnant and were tested for COVID-19. And what we really want to know is what happens to pregnant people and their babies if they get COVID-19. Next slide. We want to look at all aspects of perinatal or COVID infection. So we want to know maternal outcomes very briefly. What is the disease like in a pregnant woman? Are they sick? Are they sicker? Are they sick longer? Are they less sick? What happens to the pregnancy? Does it affect the pregnancy itself? Are there higher risk of complications? For example, routine medical complication of pregnancy like preeclampsia, high blood pressure, postpartum hemorrhage, preterm birth. Is there a higher risk of birth defects? And then understand health disparities. And I think this definitely has become much more important in the past few months of the pandemic than we knew when we started. We're also following the mother-baby dyads if there is a live birth for up to a year of life. And so we want to understand what's the rate of newborn infection, rate of birth defects, breastfeeding, and infant development through 1 year of life. And we're also collecting biospecimens to try to understand some of the biology of the virus and the disease, to understand the ways it could be transmitted during pregnancy and how often it happens, transmission in breast milk, and also to understand immune responses. And this has become really important as most of the treatments for COVID-19 are immune system related. And we think a lot of the really sick patients are from abnormal immune responses to the virus. And there is a website where you guys can enroll. Basically, anybody who's pregnant now or within the last 6 weeks that has been under investigation or tested for COVID can enroll, and we enroll patients in any language. We are, again, enrolling nationally, and the patients can be enrolled by a medical proxy if they're very ill, also to capture the full spectrum of clinical disease. Next slide. On the website, if you're curious about the study, again, there'll be information on how to enroll. You can enroll yourself. About half of our patients are self-referred, where they can sign up to participate, and we'll ask you screening questions to make sure you're eligible. And then the other half of participants have been referred by a provider, where the provider puts in their information. We contact them. There is a study dashboard, which I think is really interesting, where you can follow the study. This is as of last week. We had over 1,000 participants enrolled across the country. You can see the majority of them are COVID positive. Some of them are ended up testing negative, or our results are still pending. And about 60% of them are still pregnant. Many have delivered, and they represent participants from all over the United States.
Dr. Gao, when do you expect to be able to give us results from this study?
Yeah, that's a great question. We are publishing data as soon as we have it, in that there are certain questions that can be answered very early in the study and some questions that will just have to wait. So for example, we are compiling our data right now to describe the acute clinical course of COVID-19 and pregnancy. What symptoms do pregnant people present with? How long do they last? And are there certain symptoms that are more common or not in pregnancy? We're also putting together some of our early data on the births that have already happened, to understand the risk of neonatal transmission, and also, how the babies do overall.
Let's move on to the next slide and talk about, in the next few minutes, what do we know on the effects of COVID on pregnancy?
Right. So, I will say that we don't know enough yet, basically. And this slide is just to kind of highlight, the big take-home messages. Number one, I think this affects everybody, not just people that are infected with COVID, but there have been system-wide changes in prenatal and labor care across the world, and definitely in the United States, that affects everybody at this time. And I know, everybody here at UCSF has been affected by telehealth visits that were normally in-person routine visits, decreased number of support people during labor, and all of these kind of contribute to stress. And I think I would be surprised if there were no effects on pregnancy outcomes based on these changes over time. We do know that if you do test positive for COVID, that COVID positive moms are going to be monitored more closely. So they will have an increased risk of a stay in the ICU or stay in the hospital. Partly because some of them do seem like they get sicker than non-pregnant people, but also we are definitely more cautious in making sure that a pregnant woman is okay. The good news is it does seem like the majority of pregnancies have very good outcomes. In the priority study alone, the majority of our participants are they're outpatient, they're not admitted to the hospital, very few of them are. So nationally, of the majority of patients that are tested positive do not need to be in the hospital. The majority of them, again, have delivered vaginally so far. And so overall, outcomes are good. The racial disparities in the prevalence of COVID-19 and their outcomes is becoming increasingly clear as time goes on, and this is something we definitely need more active work on. And Dr. Scott will talk a little bit about that, where, you know, the Priority Study is very happy to collaborate with Dr. Scott and her colleagues to increase our representation and research and advocacy for these groups. We still don't know really whether pregnant women are more likely to get COVID than non-pregnant women. And the only way to really know this is to test everybody, and we're not doing that. What are the rates and the risks of asymptomatic infection? Again, up till now, until you go to the hospital to deliver, most pregnant women are not tested unless they are symptomatic. We don't know what happens if you don't have symptoms, if you don't present. And we still don't know how long moms are sick for. Kind of the early data shows that they might be sick a little bit longer. And how long are they infectious for? Like how, for example, one thing that comes up is, you know, if they are they test positive at the time of delivery, how long do they have to be careful with their baby or their family members to reduce transmission?
Dr. Gall, we have just a few minutes left. Let's go through what we know about, let's go to the next slide, Matthew, about what we know on the effects of COVID on the fetus and then also on the newborn.
So this is one thing that I think every person that is pregnant, you know, one of the first questions, can I give this to my baby? In utero, I think the majority of us are probably pretty skeptical at the beginning that SARS-CoV-2 could be transmitted transplacentally. It's pretty unusual for respiratory viruses, but there have been a few case reports, and these are single cases where they have found that the virus has penetrated the placenta, and one case where that happened and the baby was found to be positive by blood testing. And so we do know that it's possible. Thankfully, we do think it's pretty rare. You know, the vast majority of cases where we have looked for transmission in utero have been negative, and the vast majority of placentas tested have been negative. When we think about vertical transmission, it's, you know, transmission from mother to baby, but there are many places where that can happen. It can happen across the placenta, for example, during pregnancy at any point. It can also happen during the time of delivery. So either, you know, as the baby passes through the birth canal, through vaginal secretions, or through blood transfer if a C-section, and also kind of postnatally, whether it's kind of immediate, you know, caring for the baby and as a newborn. And so all of these kind of get compiled into mother to child transmission, and it can be very difficult to ascertain exactly when the transmission occurred. I don't think anybody thinks it's been absolutely proven routinely yet. I think that there was one case where it looks like probably, but it's still pretty controversial. Again, currently most data is on third trimester infections just by the nature of the timing of the pandemic. You know, it started in full force in the United States in around March. So women that were in their first trimester at that point still have not delivered. So we don't know the full impact of outcomes yet. But for the most part.
Sorry, go ahead.
Oh, you know, it seems like it's okay. There haven't been reports of, you know, a lot of abnormalities found on second trimester ultrasound. But again, we need to wait till enough pregnancies complete with documented infections at different points in pregnancy to really have a good answer for that.
I was going to say, because there are certain infections that we know when women get them in early pregnancy versus late pregnancy, it can be more dangerous or less dangerous to the infant. But what you're saying is we cannot draw those conclusions yet. It's just that the data that we have on COVID positive moms is coming, or pregnant people, is from the third trimester.
Exactly. And that's just who has delivered so far for which we have data available.
Okay.
Yeah. In the next few, you know, it takes time for pregnancies to complete.
Absolutely. That's not speeding up.
Next slide.
And so just to briefly touch on that with this, we still don't know, does COVID-19 increase the risk of stillbirths? I think, what are the other unknowns about the fetus?
Yeah, we know very little. We can say very little conclusive about the effects on the fetus at this point. There was one paper that was recently published that reported an increase in stillbirth rate during COVID times. This was out of the UK, but none of those stillbirths were COVID positive. So this may be some reflection of just being pregnant during COVID, but not necessarily COVID directly causing the stillbirth. But of course, all of this is important. And we don't know. There's just that one case out of this one hospital system in the UK so far.
Right.
And then, as far as transmitting to the newborn, we do know that there is early newborn transmission is possible, but the reassuring thing is the majority of neonates do very well clinically. There have been small case series showing that, some of these newborn babies do get a pneumonia and do need hospital care, but all that have been reported have recovered. And of course, this will also depend on the gestational age at the time that the babies are born and get infected. We still don't know how to best protect the newborn. At our hospital, we are not actively separating moms from their babies, even if they're COVID positive, unless they want to be separated. But we think that the mother to child interaction probably outweighs the low risk of transmission, especially since you're going to go home and you're going to be with your baby, want to bond with the baby and take care of the baby. And so, but it is possible. So we are recommending precautions. We think that the primary route of transmission to the neonate is through respiratory droplets, kind of your usual transmission, and not through the breast milk. The virus has been detected in breast milk, but nobody's shown that it's infectious virus that has been detected in the breast milk. It may just be viral particles that are there that are found on testing.
Oh, fascinating. So, and that's where we're seeing the studies where there's evidence of COVID in the placenta, but we really don't understand the clinical significance of that.
Exactly. I think that the contrarians against transplacental transmission say, the placenta's job is really to be the barrier. And so we've seen that it's kind of stuck, we do see the virus there, but if it doesn't meaningfully cross the placenta to affect the baby, then we don't need to cause a lot of alarm. But at this point, it's just, we don't know. We don't know.
Dr. Ga, I gave you I've given you a tall task to help us really distill down what we know so far. Any other thoughts before we move to Dr. Jaswa?
I think I just have one more slide for resources. Next slide. So the information, again, is changing as we speak. There are new studies every day. There might be a game-changing study published, this afternoon. But these websites have good up-to-date information. I would look at varied websites, as each of them will have a little bit of a different take, and especially as you're moving past pregnancy and kind of thinking about how to take care of your baby. The American Academy of Pediatrics has a very nice patient-facing website that tries to help you figure out how to care for your baby with COVID as well.
Thank you so much, Dr. Ga, for your time. I really appreciate it. I know, Dr. Ga, you have a hard stop at 1:30, so if we have any questions from the panelists, we'll plan on asking you and posting them later. Let's move on to Dr. Jaswa, if we can have Dr. Jaswa join, and Matthew, if you can switch slides. Dr. Jaswa, I know we're doing a little bit of a Benjamin Button here, but I'd like to go back and speak brief about preconception. As a reproductive endocrinologist and infertility specialist, you help people get pregnant with assisted reproductive technologies like intrauterine insemination and IVF. Many of our patients watching are pregnant. There are a few who are preconception and thinking about getting pregnant. Is it safe for women to even get pregnant at this time?
I think it's a great question. And I think I just start by reiterating what Dr. Goss said, which is that everything we know right now is tentative. You know, I have a research brain. I know lots of scientific knowledge is in fact tentative, but this is amplified with COVID in the sense that this is a new virus never before encountered by the human species. And even a 6-month experience is really quite myopic and quite a snapshot of what is to be known. So we'll learn a lot in real time. That said, I would emphasize that there are no professional societies recommending against getting pregnant at this time. And so really it comes down to pregnancy being an extremely personal choice. Everybody has a different individual story, individual timeline, individual risk tolerance of what's known and not known. And so it's not recommended to avoid pregnancy, but I think the important things to consider as individual people planning pregnancy are your own risk profile in the sense of comorbidities that might make your pregnancy or your risk for infection higher. B, what steps are feasible in your life to take to feel comfortable being pregnant during a pandemic, whether you can socially distance, what your job looks like, how much your daily exposure might be. And then C, just your own family's goals and timeline and your own comfort level with the majority of impact remaining unknown at this time, despite a lot of preliminary data that's all reassuring in terms of absolute risk sickness for either mom or baby. But the summary is, we have no suggestion that or a professional recommendation against becoming pregnant right now after full consideration of those three things.
And do we, Dr. Joshua, have any studies that show egg or sperm quality are compromised by COVID-19? And if not, are there any studies like your own that might look into this?
So the data about the impact on reproduction is extremely limited. As you might imagine, in the setting of illness, ICU patients, reproduction is often falls to the wayside as far as a research priority. And so specifically in terms of egg or sperm quality, we know very little. We can start with male fertility. I know of about 5 studies looking at COVID-infected men and sperm parameters. 4 of those 5, so data out of China, out of Italy, out of Germany, did not find any virus in the semen, but more recently a 5th study came out and did find virus in the semen. And so it's a little bit like the breast milk story, in which it looks like primarily the virus doesn't, penetrate the testicle and it appear in the semen, and even when it does, it's unclear if that's infectious or just debris from viral exposure. So there's a lot remaining to be known. I would say for male fertility and female fertility in general, the human body is smart and deprioritizes reproduction in the setting of acute illness. So men with fevers or who are acutely ill do tend to have a temporary reduction in sperm quality and sperm parameters, but there's no suggestion that with COVID infection per se, that should be long lasting. The egg is a lot harder to study, as you might imagine, because it's a lot less easily accessible. Effectively, you have to do IVF to study human eggs in a dish, and most women undergoing IVF, if they're infected, will have their procedures canceled. And so we don't have any data about the potential implications for the egg. You can extrapolate from some of those other study types that Dr. Gah had mentioned, as far as animal data or RNA sequencing data, to suggest that in general, we don't anticipate any impact on female fertility. When you think about infections that do affect female fertility, it tends to be those that are very inflammatory and cause scarring, such as chlamydia affecting the tubes, or in parts of the developing world, tuberculosis affecting and scarring the uterus. We haven't seen that picture in these early days, and so suspect that there won't be an enduring effect of the infection on female fertility.
Can you tell us, Dr. Jaswa, about this SPIRE study and what you're trying to figure out, and who might be eligible to join?
Absolutely, and thank you so much for the opportunity to talk a bit about this study. And it's really an honor to speak with Dr. Scott and Dr. Ga about a lot of the work that's going on at UCSF in light of all that's unknown, to try to fill in these gaps. We're really motivated to help figure this out. And so for the ASPIRE study, this is a prospective cohort study. We're recruiting 10,000 women from across the country, and the only eligibility criteria, the only thing you need, is to be pregnant and early in your pregnancy, so up to 10 weeks along. The goal of this study, so you don't have to be infected. This is a different design than Priority, but really complementary to some of its aims, and together we'll be able to learn a lot. The goal here, we have a particular focus on first trimester infections. As Dr. Ga mentioned, that's one of the big black holes about what are the impacts of COVID infection in the first trimester. And additionally, what are the impacts of asymptomatic COVID infection for both mom and baby? What does that mean? A lot of women might never know they got infected and carry on with their pregnancy. And unless we rigorously try to answer some of these questions, we'll miss it. So anybody can enroll. It's up to 10 weeks of gestation. You certainly don't have to have COVID to enroll. And the goal is, among other things, we're looking at frequent blood specimens. So women will prick their finger once a week in the first trimester, since that's the focus. You know, the first trimester is a time when all of the organ systems get set up, the placenta gets set up. And, you know, I think a lot of people think of the placenta as like a passive conduit, old-fashioned organ, but it really is a mediator of successful pregnancy and ongoing growth and development. And so using these frequent finger prick blood samples that women can do in the comfort of their home, will be able to follow antibody responses, detect women who never develop symptoms, really ascertain with great certainty the time point in pregnancy in which people get infected, if so, and what that means for different outcomes for mom and baby. And so we can go to the next slide, and I'll tell you a little bit more about the design of the study. And you can just click, oh, sorry, go ahead.
If we can do that briefly, please, because I want to get to Dr. Scott before the time is up too.
Of course. This is just to explain the study design of a prospective study. And the bottom line here is that by taking a group of women who, for the most part, will not be infected from the start, and following them throughout their pregnancy prospectively, you'll have a built-in control group. So you can ascertain with really scientific rigor, what is the difference between women who do and don't get infected? What were the risk factors that differentiated these women? How do the babies look differently? How do the pregnancy outcomes look differently? And so this is the goal, and we encourage anybody who's eligible to sign up for the study.
Dr. Jaswat, thank you so much for your time. I really appreciate it. I'd love to move on to Dr. Scott. I wish I had an hour with each of you, because I could sit and talk about your areas of research, which are really incredible. Dr. Scott.
Hi.
Hi.
How are you?
I'm well, thank you. I am so excited about this webinar, to have each of you speak, and I wanted to end on your area of expertise. It took us a while, but it became wildly apparent that COVID-19 disproportionately affects Black and Latinx populations and Indigenous people. It's obvious that we can't uncover why this is the case in 10 minutes. I'm not even going to pretend that that's even enough time, but my hope is that we'll have future webinars dedicated to addressing this issue. But can you help us briefly understand two questions, Dr. Scott? How do racism and racial inequities play into why these populations are experiencing the burden of COVID-19? And what are the studies that you're helping to conduct what do you hope to find to better understand the impact? And I'll let you take it away with your slides.
Yes, thank you. Okay, thank you, you all, for this opportunity to share some information about racism, racial inequities, and COVID-19. So prior to the pandemic, we were already living in a world with normalized and legalized practices, policies, and customs. They created and sustained differential access to life, liberty, and the pursuit of happiness. So about 20 years ago, a Black woman, family physician, an epidemiologist, an activist, and past president of the American Public Health Association, Dr. Kamara Jones, published a theoretical framework to help us understand racism on 3 levels using the story of the Gardener's Tale. And I invite everyone to look it up. It's online, it's free to access. And Dr. Jones defined racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities, and also saps the strength of the whole society, excuse me, through the waste of human resources. So this means that racism creates and sustains this hierarchy of humanity, really, whereby minoritized and marginalized communities such as Black, Indigenous, Latinx, and low-income communities are disproportionately impacted across and within different generations and geographies by poverty, economic destabilization, deprivation, unfair, unstable, and unaffording housing and education, voter suppression, redlining, job loss, promotion delay or denial, including state-sanctioned violence and murder. So COVID-19 pandemic has really revealed the vulnerabilities in leadership, really, and the infrastructure, the operations, and the collaborations within the healthcare and public health systems. So in my remaining time, I will briefly present 2 studies designed to examine this relationship between the pandemic and 2 different types of racism that are different, but they are related: racial capitalism and obstetric racism.
And Dr. Scott, just to briefly, what you so eloquently said, basically, there have been so many underlying causes that have contributed to racial inequities in our history so far, but it is now in a time of the COVID-19 pandemic that we're really unearthing some of, some people have known for a long time, but it's becoming more apparent to others that is the underlying cause.
Yes, it's like the pandemic ripped off, right, a Band-Aid on a wound that never really fully was, that never fully healed or got the attention and care that it needed. So we are seeing, lots of atrocities, lots of disparities, lots of inequitable things. Mean they could be prevented because the systems were already structured in a way that the Black, Indigenous, people of color, and low-income communities could not fully access and utilize things like housing, education, and essentially like their neighborhood, like in terms of clean air, access to fresh water, food insecure, like all those things were already happening. And with the pandemic requiring people to practice social distancing, that is a privilege because not all households are capable of doing that. And also particularly these communities tend to serve in what we call the essential jobs, but in those essential jobs, there's something that we call like basically racial capitalism that I'll get to that kind of explains why the impact of like their health, their healthcare experiences, the outcomes are disproportionately affecting one group in such a way that we have traditionally described these communities as having some biological vulnerability, but it's not the individual level risk. It's really looking at how these systems and structures have created opportunities, assigned value to who is able to be served with all the technology that we have. And so with this study, the Healthy Outcomes of Pregnancy for Everyone, it is a novel it's a study in the time of the novel coronavirus disease 19, or the HOPE COVID-19 study. It's a multi-year perspective study. It is designed to help better understand how COVID-19 impacts pregnancy and infant outcomes. It is led by Dr. Laura Jolie Pawlowski, and it includes investigators from 7 departments across UCSF, as well as investigators from all of UC medical centers, UC Berkeley, Seattle Children's Hospital, University of Iowa, and other private and public partners. We officially launched last Wednesday, and we have participants from about 17 different states and women from around the world. And as one of the founding co-investigators, I will be looking primarily at how, again, nativity, so people's maternal country of origin, racism and racial inequities impact their outcomes, but also looking at how it impacts their care and their experiences. So next slide. Thank you. So all women and birthing persons enroll online and they complete surveys during pregnancy to 18 months postpartum. Any pregnant person in the world can enroll in the survey-only arm of the study. The survey-only arm of the study intends to enroll about 7,500 women. The survey plus testing arm aims to enroll about 2,500 women, so a total of 10,000. We are working to make sure that at least 25% of all participants are Black, and as well as 25% are Latinx. We also expect about half of the sample will be low-income communities. Women and birthing persons in the Bay Area and eventually in Sacramento area, LA, Orange County, and San Diego will be able to participate in the survey plus testing arm of the study, which includes collecting swabs from the nose, blood specimens throughout pregnancy to 8 weeks postpartum. And there's also an option where you can opt in to provide samples from human milk and the newborn blood. The specimens are tested for the virus. They're also tested for the antibodies against the virus that causes COVID-19 disease. The specimens are also tested for other kind of molecules that help to regulate and mediate our immune system, called cytokines. And we'll also be looking at other organisms that cause disease. And participants will receive the results of their testing within a week of blood draw. Next slide. Okay, so I kind of flipped them. So this study, in terms of the COVID-19 study, does examine how the pandemic exacerbates existing hardships that I talked about, such as social isolation, economic destabilization, job loss, all of those things, including family member sickness and or death among minoritized and marginalized communities. Specifically, the study will examine how the pandemic-related hardships impact clinical outcomes, and we'll be able to characterize the peculiar experiences of illness, work, and living among Black and Latinx low-income communities compared to those in other racial, ethnic, and socioeconomic groups. Because we want to disrupt, right, these existing narratives around COVID-19, racism, racial and social inequities, our study will be able to examine the different types of support, resistance, and resilience that's needed to mitigate these impacts of COVID-19 and social and clinical experiences and outcomes. Next slide.
Dr. Scott, just to interrupt you for a second and to be mindful of the time, to our attendees, we are going to continue talking and maybe leave a few minutes at the end. So if you can join us by past 1:30, please do. And Dr. Scott, I just wanted to make a comment that these are the kinds of outcomes you were, Dr. Ga was mentioning in her discussion is what the traditional clinical studies haven't been able to capture yet, right? We not just looking at the direct effects of COVID-19 on the placenta, on the pregnancy, on the newborn, but all of the unintended consequences of it. And I think this is the first study of its kind to do that.
So yes, so there are similarities across the various studies so that we can be able to gather data to have a more comprehensive picture of what's happening at the cellular level, but also just in lived experiences. And so we are, there's surveys, there's interviews, and there's specimens. So with all three, we hope to provide, again, a more comprehensive look at how COVID-19 is impacting cellular, social, clinical outcomes.
Right.
So next slide, and now hopefully I will get to the sacred birth. So this is important for us, particularly in the HOPE study, because as other studies that we know usually blame the individual in the sense of really looking at individual level risk at the point of blaming pre-existing health conditions as the reasons why Black, Indigenous, people of color are experiencing more of an impact of COVID-19. And this type of thinking ignores how racism and other forms of systemic oppression operate in our country, so that we have these differential allocation of power, opportunities, and resources. So this is just a quote from our study protocol that was published on the 22nd of July, where we believe our study will highlight the ways in which racism structures social and labor hierarchies in the United States and within our capitalist economy. And that phenomenon is called racial capitalism. And it causes Black, Indigenous, Latinx folks to be disproportionately likely to work in occupations that increase their risk of COVID-19. So in alignment with some of the work by Dr. McClure and her investigators, we hypothesize that this elevated occupational risk is one of the major drivers for this disproportionately higher rates of COVID-19 exposure, infection, hospitalization, complications, and deaths we're observing among Black, Indigenous people of color. And it's compounded again by this differential access and utilization of healthcare and social distancing practices. So next slide, I'll talk about the last study really quickly. Thank you. So the Sacred Birth Study, it is what I am the PI of the study, and we're calling it a patient and community-informed study that's led by me and my extraordinary team of scientists and Black mothers and birthing people, Black women community leaders, and Black women artists and activists. Sacred Birth is designed to validate a new survey tool that does not yet exist, where we examine patient-reported experiences of safety, autonomy, communication, racism, empathy, and dignity in Blackness during labor, birth, and postpartum, and hospital settings during COVID-19 pandemic. Next slide. And this is just a picture of my investigators. And so Sacred Birth curates a Black women, people-focused experience in our online focus groups, our individual interviews, and the survey completion, where we prioritize and amplify the voices, lived experiences, and expertise of about 900 Black mothers, birthing people, community leaders, and scholars across California, as well as in southern and eastern parts of the United States. Our study humanizes and mandates Black women's, Black people's scholarship of discovery and innovation, again, with its peculiar experiences and observations of obstetric racism among Black people who we are trusting their participation in our study as both patient, community, and content experts. Next slide. So people are probably well aware of what the death gap, meaning that Black mothers and birthing people continue to die at rates during pregnancy and childbirth greater than any other group of people. And this is happening despite existing state and national QI initiatives, safety bundles, best practices, even in spite of technological advances, and despite traditional social and clinical protections like higher education, higher income, insurance status, even optimally using prenatal care, and sometimes even having a prior medical encounter. Black women and birthing people continue to die at this alarming rate. So we have adopted or integrated obstetric racism as the way in which we'll translate people's experiences so we can kind of quantify what's happening and really provide a higher level of detail of the experiences of Black mothers and birthing people when they birth, in the clinical interactions and the communication, the counseling, and the decision-making. So quickly, obstetric racism, it sits at the intersection of obstetric violence and medical racism, but it goes beyond the two, where it describes mechanisms and practices of racial domination and subordination in which Black women and people's reproduction, including their preconception, pregnancy, prenatal, labor, birth, and postpartum care, are subjected to these, again, really horrific, violent interactions along the lines of anti-Black racism. So in the image on your left is really a visual that describes the 7 dimensions of obstetric racism. And then on your right is how we translated that concept of obstetric racism into a scale so that the survey is organized around these 6 domains so that hospitals and health plans, public health departments can have a a better idea with data, quantified data. So they can basically have a score that characterizes the experiences of racism during hospitalization for birth. And then they'll also have a score for each of those domains. So as a hospital is trying to understand, even with, let's say, with good rates of vaginal births, right, term births, babies that don't go to the NICU, even in that situation, a hospital would say that's a great outcome, that negates the experience. So we've had Black mothers and birthing people say, even when you put me back together, meaning there was a tear, right, in the vulvar area through birth, I still don't feel whole. So that's why it's very important to have a measure of experience and not just the outcomes, because we can overlook how racism is still impacting the experience, even with good outcomes.
And I always think, Dr. Scott, when we are on labor and delivery and we make a statement, we say, you know, what we want for you is the healthy mom and a healthy baby. And one of my dear friends, Dr. Achilles Warren, and I had a conversation once where she was like, you know, it's so much more than that. And in those two lines, healthy mom, healthy baby, there is a vast range of experiences, so that when you finally do look back at your experience and you say, I'm healthy, my baby's healthy, but wow, there's such a difference in what it took for you to get to that point.
Yes.
And I think it's so important for us to be able to teach not only medical professionals so that we can better ourselves and know that at the end of the day, it's not just the health outcome that that patient is going home with, it's everything else that they experienced. Having a metric to study that is going to be incredibly important.
Yes, exactly. And so that's why I'm so enthusiastic about this, because the narratives of Black birthing people from my focus groups in 2019 really informed the scale. So it's really, again, the importance of what some folks are calling narrative medicine. So really being able to utilize the experiences, the stories, the words, the lived experiences of patients to design something that actually reflects how they feel, right, when they are experiencing healthcare. And that is what the missing gap is, that we, in our quality improvement practice, we have all these great outcomes, but they're usually grounded in clinical, right, clinical things that you touched upon. And it does not include, well, I should put it this way, it actually excludes and erases and erodes the importance of that interaction, that trust, the empathy and dignity that the entire healthcare team needs to be able to create and provide to any family. But this scale is particularly impacting communities who represent those who have the greatest burden of the likelihood of dying or nearly dying during pregnancy and childbirth. So if we are able to focus on those who are most impacted, then of course everyone else will benefit from being able to experience a birth where their safety, their autonomy, right, their communication, whatever characteristic or physical experience they have, and their empathy and dignity, like just being treated as someone deserving of having an experience where people, you know, treat you with dignity, right, regardless of what's happening. So even in complications, the ways in which we convey or communicate that to our patients really sets the difference between, again, the feeling of wholeness or brokenness. And one of the most important, right, times in someone's life that chooses to achieve a pregnancy, sustain the pregnancy, and to birth. I can't even imagine, you know, families who would celebrate birthdays, but also have to reflect upon a really traumatic experience. So that's what we're trying to do, as you said, like have a healthy baby, have a healthy mom, but also have a whole experience where people feel dignified in birth. And so next slide, very quickly, these are the patient eligibility requirements. I believe the link was put into chat. And so essentially we are recruiting Black or African-American adult mothers and birthing people who gave birth in 2020 to a live newborn in any hospital setting in the state of California and in Memphis, Tennessee. Our goal is to enroll 600 eligible patients in the state of California and 200 in Memphis, Tennessee. And why Memphis is because all the hospitals have a religious affiliation. So we'll also be able to look at how experiences of racism not only impact care, and how COVID-19 policies and practices have also impacted experiences of communities in terms of birthing in isolation, not being able to breast chest feed, your baby your own milk, as well as seeing how religion, in terms of religiously affiliated policies, may either constrain or expand people's right to have a dignified birth. Next slide. And we're almost done. This is also the patient recruitment process is like the other studies. You can self-refer, or you can be referred by providers, healthcare systems, also community referrals, because we have a body of 14 Black women-led community leaders that we meet with on a monthly basis. And that brings me to my final point. Next slide. I think this is amazing that we are partnering with Black women-led community organizations to generate and prioritize community-identified quality improvement recommendations across the 6 domains of the PREM-OB scale. And we're doing this in a new model and protocol called Community Accountability Partners. And again, this will be the first time that Black women-led community groups are going to be able to design quality improvement, a toolkit that hospitals can use that relates back to their score. So we're really trying to make sure hospitals and health plans buy into the scale, because we're providing them with ways to interpret that score, but also we're providing examples of how communities believe hospitals can improve the quality of the provision of care by combining the data of both the scale as well as information from the community. And the last slide is just what our vision is that we believe and hope by 2025 that all hospitals across the US will be utilizing a validated PREM-OB scale, as well as the community-driven, patient-focused quality improvement prioritization data to transform hospital birth care experiences and outcomes for Black birthing people.
Dr. Scott, thank you so much. And I really look forward to being able to use this scale in the hospital setting. I am so appreciative for the 31 of you who are still joining us for this talk. I know we've gone over, but all of this I find so fascinating and interesting. So all of the information on the studies are in the chat. I'd like to ask one question that we had asked Dr. Ga, but a question to ask you, Dr. Scott and Dr. Jaswa. When can we expect to see some of the results of your studies? Dr. Jaswa, or Dr. Scott, let's start with you.
Oh, okay. So we will be, for both studies actually, so for the HOPE study, we will be providing results on an ongoing basis on a data like dashboard. And for Sacred Birth, we are going to do something similar, that as enrollment for our study starts in September. So we're going to be providing kind of big picture summaries of the data that we get, again, around people's experiences in a composite score, as well as those domain specific scores. And we're going to release data according to like region. So Northern, Central, and Southern California, we're going to do it online. We're also going to host some kind of online town hall meetings to share the data with the public. We'll also be working with our hospital partners to share their own data with them as well. And we'll be utilizing social media, such as Twitter, to have tweet chats. And as well as Facebook Live discussions around the data and what the community, the public, feels about that data and how they can partner with the hospitals to make it better.
Wonderful. And so everyone, I encourage you to check out the websites for those informations. How about you, Dr. Jaswa? When can we hear about the Aspire study?
For sure. So similarly with Aspire, the goal and the priority is that this information is intended to be as real time as possible to help assuage concerns and inform all the stakeholders, which is really everybody, pregnant women, families, pregnant people, policymakers, healthcare providers. And so the timeline for expected results really is a function of exactly what subject matter we're talking about. So some of the early pregnancy outcomes as far as miscarriage risk in the first trimester might be available sooner, as in hopefully by the end of the calendar year, we'll have some preliminary information that we intend to share in real time. Some of the baby outcomes, really you can't ascertain some of the neurodevelopmental behavioral kind of outcomes till they're 18 months. And so that's a much longer game. And so we're acutely aware of the balance between speaking too soon and speaking with an informed approach without causing harm through conjecture. And so taking into that balance, there'll be kind of just a natural timeline and gestation of what type of results are available. But certainly, just like Dr. Scott's beautiful studies, the goal is to have available data for everyone in real time as quickly as possible.
Thank you. And to everyone who's still joining, I know there were questions about specific recommendations for travel and how to think about daycare. We've addressed some of those in our previous Women's Health webinar study. So there's one on where we spoke to the pediatricians about recommendations. I urge you to look at those. And I think there's definitely a need. We will be continuing this Women's Health webinar series, and we'll talk to our colleagues in pediatrics and again in obstetrics in the future to give you a little bit more guidance. As you see today, our goal was to show you why it's been difficult to make any to draw any conclusions with certainty, because as you know, these conclusions greatly impact not only what you do, but your experience, how much you choose to go out into the real world, what you decide to do with your older child who is potentially thinking about, going to preschool or summer camp. And so I think a lot of the times you can talk to many different medical providers and get different answers. And that can feel very frustrating, but it's coming from a place of trying to draw conclusions from data that is sometimes not as strong as what we would want it to be, but also because we don't know what this is going to continue looking like. And I think that's what's been really hard for me, in that I thought we would be in a better place right now. I did not expect that we would be in a place where we were seeing California being one of the states that has the highest rates, that's now superseded New York. So I think we are going to continue coming to you with the information that we have. We are going to continue coming to you with updates in our policies, and we appreciate your patience in this, in helping us continue to provide care for you. I really hope you left today with a better framework of understanding current statements on pregnancy and COVID-19 and how we sift through the studies, conclusions we can draw from the current research on COVID-19 and pregnancy, the studies that are being conducted at UCSF and many other institutions across the United States to further our understanding of COVID-19 and how you can become involved, and how racism and racial inequity have played into who is disproportionately affected by COVID-19 in the United States. I want to thank Matthew Wade, who is our patient navigator at UCSF, Bertina Lee and Verndine Tortorelli at the Women's Health Resource Center, and Rosa Arce from our interpreting services, as we were able to provide interpreting for some of our patients who joined today. We'd love to get your feedback on how we did and how we can improve our webinars in the future by having you fill out an evaluation we'll send out shortly. Thank you so much for sharing your day with us. Dr. Jaswat, Dr. Scott, and Dr. Gah, who had to leave, I am so grateful for your time, and I look forward to speaking to you more in the future. Bye, everyone.
Bye. Thank you.
Bye.